All right, so I want you guys to be able to see me, but I really want you guys to be able to see my little makeshift whiteboard here. So I decided to talk about the thyroid and hypo and hyperthyroidism because there is a blog post on the website right now that touches on or goes over this topic. So I decided to go ahead and make a video talking about these two different disorders. I know endocrine gives students a lot of trouble sometimes. One of the things that I tell my students is think of it this way. If you remember one endocrine disorder, then you have got the other one down, right? Because these endocrine disorders are typically polar opposites of each other in terms of their signs and symptoms and manifestations, right? So a little bit about the thyroid. So the thyroid, basically responds to thyroid stimulating hormone, which is produced by the anterior pituitary. And when it is stimulated by thyroid stimulating hormone, it cranks out its hormones, which are T3 and T4, which increase our metabolic rate in a nutshell. The thyroid also releases a hormone called calcitonin, and I say that calcitonin tones calcium down in the blood because calcitonin pulls it from the blood and puts it into the bones, all right? But the main hormones we're going to focus on here are T3 and T4, okay? So hypothyroidism, again, they are going to be complete opposites of each other in terms of manifestations, and it's all about learning those unique manifestations of each disorder, of any disorder that you're going to learn about, okay? So a little bit about the pathophysiology, because you got to understand that underlying patho to understand why you're doing what you're doing for these patients. So you'll see that both of these disorders, both hyper and hypothyroidism, stem from an autoimmune issue. So with hyperthyroidism, the most common underlying etiology is something called Graves' disease, where there are autoantibodies that are produced causing the thyroid to overproduce and over-release T3 and T4. So what that causes, since we know that T3 and T4 increase the metabolic rate, an overproduction of T3 and T4 really increases the metabolic rate, okay? So everything is gonna be sped up. So think in terms of tachycardia, think in terms of diarrhea, diaphoresis. That metabolic rate is increased. So you're gonna see weight loss. You're gonna see hypertension more than likely. Cardiac dysrhythmias from that overstimulation, that over-activation of the sympathetic nervous system. So everything is sped up. High temperatures, okay? So all those are common signs and symptoms of Graves'. The unique signs and symptoms or manifestation is something called exophthalmos, and this has to do with the eyeballs, right? So these patients have this bulging eye appearance, and this is called exophthalmos. And this occurs for some reason because there are little connective tissue deposits that are deposited within the orbital sockets behind the eyes in patients with Graves' disease. And it causes that bulging eye appearance. You may also see a goiter, and all a goiter is an enlargement of the thyroid gland, okay? And so it's being told by TSH to produce and produce and produce T3 and T4, and so in response, it enlarges, causing the appearance of a goiter. So we have, hyperthyroidism. People walk around with it every day, but let's say something happens to one of these patients and they have a stressful event, they get COVID, or they have to go in for an unexpected surgery, or they lose a loved one, anything that causes stress, that can throw these patients with underlying Graves' disease into a medical emergency, and we call that thyroid storm. So you think about this as like the body is just being stormed with over acceleration. All right, so you have that extremely high blood pressure, that extremely high temperature or hyperthermia, extremely high heart rate. And I have temp on here twice, which I really wanted to drive that point home. But one of those should be heart rate. So those are the things that you're really going to be watching for, and that is what can kill your patient. Hyperthyroidism, the medical emergency thyroid storm is much more deadly than hypothyroidism, okay? So also with lab work, you know, it's always important to look at those labs. T3 and T4 are obviously going to be way up, right? Because the thyroid is being stimulated to produce and produce and produce. However, TSH will be down because of that negative feedback that's going back to the anterior pituitary saying, hey, whoa, we've got enough T3 and T4. Stop releasing TSH. So T3, T4 will be up, TSH will be down. So what are some of the nursing interventions? I'm not big on nursing diagnoses and all that kind of stuff, but as far as nursing interventions, you just take it back to, all right, what are our signs and symptoms, okay? So our signs and symptoms, increased blood pressure, increased heart rate, so tachycardia. A lot of times you'll see physicians or providers prescribe beta blockers like Inderol that are going to treat that heart rate and treat that blood pressure as well. Always big on exams is, you know, making sure that the environment is quiet and calm for the patient because they do not need to be overstimulated. Always avoid over palpating someone with, you know, underlying hyperthyroidism, because you could send them into thyroid storm by vigorously palpating that thyroid. You want to make sure they're kept cool, okay? So, you know, cooling blankets, sedatives if anxiety is, you know, further increasing their heart rate, that sort of thing. Patient teaching, you know, we're going to make sure, because metabolism is increased, so when these folks are ready to get discharged and go home, you want to make sure that they're maintaining like a high calorie diet, right? Because that metabolism is increased. So nutrition is always huge on exams, so remember that. Some of the medications that we might administer, methimazole, is it blocks synthesis of T3 and T4, as does PTU. PTU is safer in pregnancy. Remember that. That's always like big on exams, right? So remember those two medications. We're also going to, you know, obviously encourage frequent rest periods for these patients to minimize overstimulation, overexertion. And another medical treatment that you might hear about is something called radioactive iodine. So iodine is very, very readily taken up by the thyroid. It just eats it up. So what a provider might do is make some iodine radioactive and inject it into the patient. It goes in and kills the thyroid. Of course, if we do that, you know, death to the thyroid, then obviously they're going to have to be on Synthroid or, you know, thyroid replacement medication for the rest of their life. All right, so on the flip side, with hypothyroidism, everything is hypo, low and slow. So this is also an autoimmune issue. This one is called Hashimoto's. I guess these diseases were named after whoever discovered them. I don't know. But in this respect, you still have autoantibodies, but they're directly attacking the thyroid tissue itself, so it can't produce enough T3 and T4. So that leads to your signs and symptoms of hypothyroidism. So remember, low and slow. Metabolism is slowed down. So you'll see bradycardia, you'll see weight gain, you'll see constipation, you'll see just kind of lethargy, everything, you know, just low, slower heart rate, lower, you know, blood pressure. The unique manifestation associated with hypothyroidism is going to be something called myxedma. And this again goes back to the eyes. It's always with the eyes with the thyroid, right? So what myxedema is little deposits of fluid collections underneath the eyes. So the eyes always look very puffy, like the patient did not get a full night's sleep the night before. And so that's myxedema. So that's that unique manifestation associated with hypothyroidism. So with our medical emergency with hypothyroidism, again, any stressful event can throw someone with underlying Hashimoto's into a medical emergency, and it is called myxedema coma. So you're going to see all those signs and symptoms, but you're going to see them to the extreme. So very low blood pressure, very low heart rate, low level of consciousness, which this places these patients on an aspiration risk. Again, nutrition, aspiration risk, ABC, that's airway, so that's always going to be important to remember. So with these patients, you know, obviously then the T3 and T4 is going to be low. And because of negative feedback, the anterior pituitary thinks, hey, there's not enough T3 and T4 circulating, so I'm going to keep producing TSH in hopes to get those levels up. So T3 and T4 will be low, TSH will be elevated. So what are we going to do for these patients as far as their medical emergency? High doses of levothyroxine, right? Which that's our thyroid replacement medication. We've got to keep these patients warm. So, you know, warming blankets, whatever that might take, because they're very prone to hypothermia, very low body temperatures. Frequent rest periods for these patients as well. High fiber diet, low calorie diet. Remember, nutrition is always important. So why low calorie, high fiber? Well, we just talked about how they're prone to constipation. So we want to increase their fiber intake, but low calorie because their metabolism is so slow that they're prone to or susceptible to weight gain. Okay. Also, these patients, you know, at discharge, they need to be told that they're probably going to need to wear a medic alert bracelet. So if they pass out in the grocery store, then, you know, somebody can see the bracelet and know that, hey, this patient has, you know, very severe hypothyroidism. And the EMT team, when they arrive, you know, they know exactly what to do. One of the things that I forgot to mention with hyperthyroidism patients, they need to be taught to weigh themselves daily, okay, because of that risk for, you know, nutritional deficiencies because of that really high metabolic rate. So we're actually more concerned with weight loss, not meeting their metabolic needs with a hyperthyroid patient than we are with weight gain with a patient with hypothyroidism, okay? So always remember, you know, those nutritional issues with both of these types of patients. So I hope this kind of, you know, helps maybe clear up some of the questions that you have about these two disorders. And I hope I did it in a succinct way that you're able to understand. Please keep watching for more videos and keep an eye out for more resources. I'm really excited about what's to come for the website, and, you know, hope you guys will, you know, continue to learn from me. Thanks.